Hello and welcome. We'll take just a second to let everyone get in the room. Thank you so much for joining us today. We'll go ahead and start in just a moment as you all come into the room. If you are looking for the webinar Syphilis 201, you are in the correct place. All right, it is 11:01, so we will go ahead and get started. Hello, my name is Destiny Kelly, and I am the manager of the NNPTC National Coordination Center. And thank you so much for joining us today for Syphilis 201. Next slide. This training is in alignment with the 2021 STI treatment guidelines and peer-reviewed research. We recognize the CDC may be in process of modifying the 2021 STI treatment guidelines to comply with recent executive orders. Upon receiving additional guidance from CDC or the release of updated STI treatment guidelines, we will ensure our training content aligns. Next slide. The NNPTC network is made up of 8 regional prevention training centers, known as the PTCs, and 2 national centers. We train clinicians in the diagnosis, management, treatment, and prevention of STIs. We also provide technical assistance to clinics. You may recognize some of the names and logos of our 8 regional PTCs. Our 2 national centers include the Coordination Center and the National STD Curriculum. Next slide. The NNPTC proudly hosts the STD Clinical Consultation Network, known as STD-CCN. Now, this is a free online system where clinicians can submit complex STI questions, and an NNPT expert, like the ones we're going to hear from today, from one of our PTCs, will answer in 1 to 5 business days, depending on your need. Clinicians can receive this information by email, phone, or even text. Please don't forget to register for our last webinar in our 3-part series, Congenital Syphilis and Syphilis in Pregnancy. This will be next Wednesday, February 26th at 1 p.m. Eastern Standard Time. If you're unable to use this QR code, please visit nnptc.org, then navigate to training. Next slide. Now I'd like to introduce our speakers for today. Dr. Arlene Senya is a professor of medicine at the University of North Carolina at Chapel Hill Institute for Global Health and Infectious Diseases, an adjunct professor of epidemiology at UNC-CH Gilling School of Global Public Health, and a faculty member for the Southeast PTC. Dr. Khalil Ghanem is a professor of medicine in the Division of Infectious Disease at Johns Hopkins University School of Medicine, in the Division of Population, Family, and Reproductive Health at the Johns Hopkins Bloomberg School of Public Health. He is the principal investigator at the Prevention Training Center at Johns Hopkins, and he was a consultant to the CDC and development of the 2010 and 2015 Adult Syphilis Treatment Guidelines. Falana Lang is a physician assistant at the St. Louis PTC and is our moderator and will help navigate audience questions. We will take as many questions as time allows using the Q&A function, but please understand we may not be able to get to all questions. If you have a specific patient question, please submit that to stdccn.org. This webinar will be recorded and available soon on the Denver PTC YouTube page. And now, without further ado, I would like to turn it over to Dr. Arlene Senya. Thank you.
Thank you, Destiny, and good morning or good afternoon to everyone. Hope everyone is staying warm on this wintry day. So I'd like to start with just going over our disclosures. We have grant funding from the NIH, NIAID, Bill and Melinda Gates Foundation. Also, we have support from the American STD Association. I have disclosures from UpToDate, as well as Hologic and Innoviva for consulting work, as well as on the scientific advisory board. But none of these really are in conflict with what we're discussing today. So these are the objectives of our presentation. So during this presentation, We will hopefully provide you with information regarding how best to interpret serological tests for syphilis, also how best to manage patients with syphilis and serological non-response or serological failures. Also, we want to characterize the benefits and unknowns related to the use of DoxyPEP and its impact on syphilis, as well as how best to diagnose and manage neurosyphilis, ocular syphilis, and otic syphilis. So I will review case 1. So next slide. So our first case is a patient who presents to your clinic, and results obtained today demonstrate a treponemal chemiluminescence immunoassay, or CIA, that is reactive, and a reactive RPR with a titer of 1 to 8. The patient states that he was diagnosed with syphilis 1 year ago based on a point-of-care test performed when he was at a nightclub, and he was treated with a dose of benzathine penicillin. So now what do you do? So first, it's very important for us to review syphilis serologies because we really need to understand what these tests are actually providing us as far as information regarding staging and the rules of interpretation. So based on what we typically have used in the past, the non-treponemal tests, so this includes the RPR and the VDRL. So they tend to be non-reactive in 30% of persons with primary syphilis. So remember that window period that occurs in the first very early primary stage. And they can also be non-reactive in persons with prozone reactions. So prozone reaction is when you have a patient with primary or secondary syphilis. Their antibodies are very high, but it overwhelms the antigen on the test. So you have a false negative test. So false positives, however, with the non-treponemal test can occur with older age, autoimmune diseases, HIV, and other infections. And so remember that the RPR, for example, may become non-reactive over time with or without treatment. So typically we, as I said, see that window period in early primary, but we may also see a negative test in someone with latent infection. So the treponemal test, in the reverse algorithm, this is what we started with our patients. So there's different types of treponemal tests, the enzyme immunoassay, the CIA, and traditionally we've had the FTA antibody and the TPPA. So remember that there's also limitations. They also do have a window period in 30% of persons with early primary syphilis. False positives can occur just like for the non-treponemal test. And so the treponemal test, although they're very specific, can also detect, for example, other types of treponemes, for example, treponema denticola, which can cause severe gingivitis. But typically they are specific, at least for the patients that we're seeing with suspected syphilis, but false positives can occur. And once reactive, remember that they always remain reactive, independent of treatment history. And this table here on the right just sort of shows what we have in this patient. Is actually on the third line. We have a traditional and reverse sequence where you have, in this case, a positive treponemal test and a positive non-treponemal test, which indicates to us that the patient has either untreated syphilis, treated syphilis, or less likely to have some other treponemal infection. Next. So let's talk about the point-of-care test. So a really important point here is all of the point-of-care tests that are currently available in the US are detecting treponemal antibodies. So there's 2 FDA-cleared tests you can see here, the Syphilis Health Check and then the ChemBio. So the ChemBio actually detects both HIV and syphilis, and you can see 2 lines there on the card. And then, of course, there's the NowDX, which is the first at-home test that's available or going to be available very soon that will be over the counter. So as I already mentioned, please remember that all these tests detect treponemal tests. The NowDX test actually has a great website that does inform patients that if they're doing this at home as an over-the-counter test, is that it actually educates them that the treponemal test may detect prior syphilis, and would clearly all these tests would need RPR testing for additional testing or an evaluation. Next slide. So how do you interpret a treponemal antibody only test? So with these point of care tests or at-home tests, remember, as I already mentioned, that the point of care test reveals just a treponemal antibody. So if it's non-reactive, it may indicate that the patient does not have syphilis or may have early syphilis. If the point of care test reveals a reactive treponema result, then this may be a false positive treponema result if the patient is really not at risk. It may indicate treated syphilis or untreated syphilis. Next slide. So what to do with this patient? So the health department was contacted. There are no additional details about his diagnosis 1 year earlier. Presumably, he had early syphilis that was treated, but we don't have a baseline RPR. So it is really unclear if he achieved a 4-fold decline in titers. So we don't have any context there. So clearly what we need to do is obtain a good history and perform an examination. So we want to get a history of whether there's been re-exposures that could put him at risk for reinfection. And then we want to assess for any signs and symptoms that could suggest ocular, otic, or neurosyphilis. If any of his signs or symptoms point towards ocular, otic syphilis or neurosyphilis, then we'll go over that later. Khalil, Dr. Ghanem will go over best management for those indications. But if the above are unrevealing, there are two options. One is you can continue to monitor him serologically. So perhaps, if you're concerned about reinfection, maybe have him come back in 2 weeks. Or if you just want to monitor serologically and you're not planning to treat, you can repeat that test in 1 to 3 months and assume he was adequately treated. But if you are concerned that he has potentially have reinfection and his titers have not declined 4-fold, perhaps after treatment, if that's a concern, you would choose to treat again. Because as I said, if you have a real concern about reinfection in high-risk individual, or if he's unlikely to return back, for monitoring, or if in this case is a female patient who's pregnant, please, be conservative and go ahead and treat, although you might not know what his prior titers are. And really what's important here is having a discussion with the patient, understanding where he, she, or they are at as far as their risk for reinfection, and making that decision with the patient regarding next steps. Next slide. Okay, I'll turn it over to Khalil. Okay.
Thanks, Arlene. Hi, everyone. Delighted that you're joining us today. So with our patient here, let's assume that we are seeing the patient now, had a re-exposure. And so we're concerned about reinfection. Obviously, we're going to retreat the patient, but we're also going to have a discussion with the patient about DoxyPEP. I know you've all heard about post-exposure prophylaxis, and we have a discussion, shared decision-making, and he decides he'd like to have it prescribed. And so the question here for all of us is, what are the potential implications of DoxyPEP on syphilis management? And so I just want to remind everyone that DoxyPEP, or doxy post-exposure prophylaxis, has been shown to be extremely effective at preventing both chlamydia and syphilis, and some data that are plus minus for gonorrhea in preventing these infections among individuals who are MSM or transgender women. Keep in mind, remember, that the data for cisgender women as of yet do not show benefit, but there are ongoing studies looking at that population. So the recommendation is to consider using DoxyPEP with shared decision-making in individuals, either MSM or transgender women, who essentially have had a curable STI in the prior 12 months. The intervention is giving doxycycline 200 milligrams. So if you're using a 100 milligram tablet, they take 2 tablets. If you're using a 200 milligram tablet, you take 1 tablet. And the goal is to take the tablet within 72 hours of a sexual exposure. If somebody has sex, daily, then they can take a daily tablet of 200 milligrams. That's the maximum dosage, 200 milligrams daily. Or if they're not having daily exposures, they would take the tablet within 72 hours of that exposure. And so DoxyPEP recommendations are available on the MMWR and CDC websites, and they are summarized on this slide with follow-up recommendations for the follow-up visits also summarized on this next slide. And you can access the full recommendations online. Now, DoxyPEP, there are emerging data. Not only do we have randomized trial, but now we have ecological data. In cities where DoxyPEP was introduced, they have started seeing significant declines in the rates of chlamydia and in the rates of syphilis. I show you here the experience of San Francisco and the Kaiser experience on the right, with significant declines once DoxyPEP was introduced. So it's a very effective intervention, and you should definitely consider it in the right patient population. Now, the big question is, DoxyPEP and syphilis, what should we expect among the 30% of patients who are taking intermittent doxycycline as DoxyPEP, but about 30% of those who are taking DoxyPEP are going to have a breakthrough infection with syphilis. So DoxyPEP reduces the incidence of syphilis by about 70%. 30% of people who are taking DoxyPEP are going to get syphilis, but they're taking intermittent doxycycline. And remember, doxycycline is very effective at treating syphilis. Early syphilis, you have to use 100 twice a day for 2 weeks. And for latent syphilis, you're using 100 twice a day for 28 days. So these patients are not getting the full treatment course. They're just getting intermittent doses of doxycycline. And the question is, what would it do to the clinical manifestations of syphilis? And what would it do to the serological manifestations of syphilis? And the answers to this is, we don't know quite yet. But we should be prepared for the following. And I'm hearing a lot from my colleagues that are seeing patients that they are observing some of these manifestations. From the clinical manifestations, it is entirely possible that the intermittent use of doxycycline may attenuate some of the clinical manifestations of syphilis. So a patient may not present with a juicy, beefy ulcer, but they may present with a small lesion, or they may not present with any lesions at all. It is possible that the DoxyPEP, the intermittent doxycycline, may change the clinical manifestations of these lesions. From the serological standpoint, it's also possible that the intermittent use of doxycycline, if somebody does get infected with syphilis, may not allow the titers, the RPR titers, to go up fourfold. So you may see a patient, for example, a colleague of mine recently saw a patient with an ulcer, but their titers had remained stable and had not gone up. They treated the patient with penicillin, the ulcer went away, and the patient had been on DoxyPEP. So it's possible that you may not see an increase in titer. And so knowing that the clinical manifestations may be attenuated, that the serological manifestations may be attenuated, you're going to use your best judgment when you see a patient who's taking intermittent doxycycline, and you'll then need to decide whether you think the patient got infected and you should treat them, or whether you don't think that the patient is infected. So this is your best clinical judgment. I know it doesn't feel great because there are no hard and fast rules, but this is the best that we can do for now. So stay attuned to the possibility that the clinical and serological manifestations of syphilis may be different in those taking DoxyPEP, but in most instances, I bet the clinical and serological manifestations will be exactly the same, whether they're taking DoxyPEP or not. So thanks very much, and I'm going to hand it back over to Arlene for our second case.
Okay, I'm just going to comment one more time about case one because there was a question in the Q&A. The bottom line for that patient is that you determine whether or not he is at risk for reinfection. If so, you would go ahead and treat. But otherwise, you would monitor serologically. As Khalil said, you want to offer that patient who is at risk for DoxyPEP. And if he is already taking DoxyPEP, would that have altered his presentation? Possibly, but we don't know that information yet. Okay, so moving on to case two, we have a 35-year-old woman with no past medical history. She presents for a routine annual visit. She was last evaluated 2 years ago. She is asymptomatic now, and she's doing well. She reports 3 sexual partners in the prior 2 years. She has been monogamous with her current partner for the past year, and she requests STI testing. Her physical exam is unremarkable with no signs or symptoms of syphilis. However, her test revealed that she has a reactive treponemal test and a reactive RPR with a titer of 1 to 32. She denies a prior history of syphilis and does not recall observing any ulcers or skin rashes. So she is diagnosed as having latent syphilis of unknown duration, and she's treated with a weekly dose of benzathine penicillin for 3 consecutive weeks. Her current partner is tested, and his serologies are non-reactive. On follow-up, over 2 years, she remains clinically well, and her titers are as follows. Initial titer was 1 to 32. At 3 months, it was 1 to 32. 12 months, it was still 1 to 32. And at 2 years of serological monitoring, she remains asymptomatic with a titer of 1 to 16. So what do we need to do here with our titers that have not declined fourfold? Great question. Okay, so let's walk through first the serological definitions after treatment. So after therapy, remember that we define serological cure as a fourfold or 2 dilution decrease. So for example, 1 to 32 to 1 to 8. So the CDC treatment guidelines in general is that you want to see the serological cure at 12 months for early syphilis and 24 months for late syphilis. Although you can see that we've started, you can wait up to 24 months for patients with early syphilis and HIV because they can have a delayed serological response over time. So another definition is a serological non-response. We used to refer to this as serofast, but we're trying to move that terminology to non-response. And so these may be individuals who have not achieved a fourfold decline at 12 to 24 months. And some of our prior studies have shown that this is expected to occur in about 12% of individuals with early syphilis. Now, there's serological failures. So that means it could be an individual with a serological non-response, but they have sustained fourfold increase in titers. And I'll talk about what sustained means in a minute. And then last but not least, we've talked about reinfection. This could be a patient with actually a fourfold decline in titers, but then they have sustained fourfold increase, or maybe they were a serological non-response and then they have a sustained fourfold increase. In any case, it's often very difficult to distinguish between treatment failure and reinfection. The only way to do so is by history. And then you can see here just an example of what we mean, just if it's not clear already, what a fourfold decline means. Next slide. Okay, so let's walk through the scenarios here. So in this case, we're going to call the patient a serological non-response. She remained at 1 to 32 and then 1 to 16. So first you need to assess if she has any neurological, ocular, otic signs or symptoms. If she does, then you need to manage accordingly. And as I said, Dr. Ghanem is going to go over that in more detail, but certainly consideration about lumbar puncture, ocular referral to an ophthalmologist, and so forth. So if she does not have any neurological signs or symptoms, question is, did you wait long enough for the titer to decline? And in that case, you waited 24 months. If you, really were only monitoring for 12 months, maybe it's not long enough, is that you just keep monitoring. Remember that the patient had syphilis of unknown duration. So in that case, you did need to follow up to 24 months. So yes, if you monitored up to 24 months, the question is now, did the patient get reinfected or is she pregnant? If yes, then remember what we talked about is that you would want to definitely retreat for reinfection with 1 dose of benzathine penicillin, or if she's pregnant, you want to be conservative and retreat due to concern about possible congenital syphilis if she wasn't treated appropriately. But let's say the answer is no. Question is her titer greater than 1 to 64? Now, this is, sort of probably from our perspective, important for me to clarify is that, most of us think of the RPR as really being a good marker for the actual treponemal burden, because even though it says non-treponemal, it's actually detecting cardiolipin on the surface of circulating treponemes. So there is correlation with disease activity. So when you have a titer that's like greater than 1 to 32 or greater than equal to 164, you do get concerned that possibly, perhaps this patient is a treatment failure. So you do want to consider CSF examination. So if the titer, as in her case, was 1 to 16, was a no, then you keep following her titers There have been 5 observational studies that show no difference in intermediate-term outcomes between treatment and watchful waiting. If you feel better retreating, do so, but only once. This is Khalil's point, is that, we both see patients have been retreated over and over, benzene, penicillin times 3 doses for titers that don't decrease. So just something to consider is that, at some point, you should be assured that people have been retreated repeatedly and have just not declined. That may be a persistent immunological response and not necessarily a treatment failure. Next slide. So case 2, she continues to be monogamous and she's asymptomatic. No additional treatment is recommended. And lo and behold, 12 months later, so she's now probably 36 months after her initial treatment, her titer is 1 to 4. However, she represents 12 months later and her titer is now 1 to 16. Next slide. So what do we do now with her titers that have increased 4-fold? Okay, so now we're concerned about serological failure because, as I said, she went from a 1 to 4 to 1 to 16. Next slide. So we go down the same algorithm. Are there any neurological, ocular, otic signs or symptoms? If yes, manage accordingly. But if no, then this is what we mean about sustained. So remember that titers can fluctuate for many different reasons. It could be because someone has a viral infection, or maybe it's a difference in the laboratory that's doing the titers, but you do want to repeat them. So if they are elevated, then we'll go down that path. But if no, I'm sorry, if you didn't repeat the titers, then you want to repeat them. If they are still elevated at 2 weeks, then we will go on to the next slide. Question is whether there's reinfection. So if there is a possibility that there is reinfection, then it's obvious you want to retreat. So in this case, if you're concerned about reinfection, then you would treat her with 1 dose of benzathine penicillin. But if there's no reinfection and there's titers are still elevated, sustained at 2 weeks later, you want to consider a CSF examination because we do get concerned about treatment failure when you have that 4-fold increase and that's sustained. However, there are no data comparing outcomes for patients who undergo a CSF examination versus empiric retreatment with 3 doses of benzathine penicillin without a CSF exam. So the CDC guidelines do recommend considering a CSF examination, but as we said, there's really no really good data to say what's best as far as management. Okay, so in this case, the patient reports a new sexual partner in the prior 6 months. She does not recall any rashes or lesions, but due to the fact that reinfection is possible, she's treated 1 dose of intramuscular benzathine penicillin, and her partner is tested, and he's diagnosed with latent syphilis of unknown duration and is treated. Okay, I'm going to turn this over to Khalil. If there's any questions about the case, we can address it at the Q&A. Thank you.
Thank you, Arlene. So our final case today, and hopefully we're going to have plenty of time to answer some of your questions. Our final case today is going to be dealing with the neurological CNS complications of syphilis. And so our patient presentation is a 38-year-old cisgender woman with a history of HIV that's well controlled on Biktarvy. Her last CD4 count was 875 cells, and she has an undetectable viral load. She presents with rash, fevers, chills, a new onset headache, mild photophobia in both eyes, and discomfort in the right eye associated with vision loss. Her past medical history, she was diagnosed with HIV 6 years earlier, and it was acquired from her male partner. She has been well controlled on her ART regimen without any complications. Social history, she reports a new male sexual partner in the last 2 months with intermittent male condom use. And so her physical reveals that she's awake, alert. She's sitting in the dark room. The light bothers her eyes. Her neck is supple. Her ophthalmological exam reveals panuveitis. And she has a skin rash, which is shown here in the pictures. No other neurological findings. Her pelvic examination was normal, and the rest of the physical exam was normal. Her lab evaluation revealed a normal CBC and complete metabolic panel. her urine pregnancy test was negative, her UA was normal, and the NATs for gonorrhea and chlamydia were non-reactive. And unfortunately, though, her T pallidum CIA was reactive, and her RPR was reactive with a titer of 1 to 64. So this patient who presents with headaches, visual changes, and a rash, the diagnoses on her, clearly she has secondary syphilis. With the headache and the photophobia, you would strongly worry about early neurosyphilis, right? And certainly with the panuveitis, unless there's another cause for her uveitis, she has ocular syphilis. And so she's got essentially, potentially 3 diagnoses related to the syphilis. And so let's talk just a little bit here. And I want to remind you of something really important. After infection, remember that in about half of the patients who get infected with syphilis, within hours to days, the organism has already spread to the central nervous system. And so within hours to days, that organism in many patients has already gotten to the central nervous system. As a result, knowing that, you know that neurosyphilis, ocular syphilis, and otic syphilis can occur during any stage of the infection, whether it's early or whether it's late. That's why it's so important when you see a patient with syphilis, any patient, any stage, always ask about the potential for neurological involvement, eye involvement, or inner ear involvement. It's critical because these manifestations can occur during any stages of the infection. I just recently had a patient who had symptoms of meningitis. At the time of admission, had no other manifestations, was admitted to the hospital, started on penicillin, and about 48 hours later developed an ulcer. So he had early neurosyphilis even before primary syphilis. So it's really important to keep in mind that these manifestations can occur even at any stage of the infection. Now, with neurosyphilis, when you do a lumbar puncture, the lumbar puncture is going to be abnormal. If the lumbar puncture is completely normal and you suspect neurosyphilis, they don't have neurosyphilis. So a normal lumbar puncture rules out the diagnosis of neurosyphilis. But a normal lumbar puncture does not rule out the diagnosis of otosyphilis and ocular syphilis. So you can have people with otosyphilis and people with ocular syphilis that have a completely normal lumbar puncture, but you still have to treat them with 10 to 14 days of IV penicillin, just like neurosyphilis. So things to keep in mind with ocular syphilis and otosyphilis. Let's start with ocular syphilis. Up to 40% of patients will have a normal lumbar puncture. So you don't need to do a lumbar puncture to make a diagnosis of ocular syphilis if the patient only has ocular signs and symptoms. You just have to have them evaluated by an ophthalmologist, and if they find any abnormality in the eye, and there's no other reason other than syphilis for them to have that abnormality, then you made a diagnosis of ocular syphilis, you stick an IV in the patient, and you treat them for 10 to 14 days of IV penicillin. Ocular syphilis can affect any part of the eye, from the front all the way to the optic nerve. And it can affect patients in one eye in 50% and in both eyes in the other 50%. Again, the CSF exam, the lumbar puncture, will be normal in up to 40% of patients with ocular syphilis. What you need to do is to refer the patient immediately for an ophthalmology exam. If you can't get an ophthalmologist, refer them immediately to the emergency room. Tell the emergency room doctor, hey, listen, I'm sending you a patient. I suspect they have ocular syphilis. Have an ophthalmologist do a good ocular exam, a slit lamp exam. And if you find any abnormalities, you don't need to do a lumbar puncture. Just put in a long-term line and start IV penicillin for 10 to 14 days. That's ocular syphilis. Otic syphilis, the clinical manifestations can be hearing loss or tinnitus, ringing in the ears, or vertigo, dizziness. Those are the main clinical manifestations. it can affect one side in 50%, both sides in the other 50%. The vast majority of patients with otosyphilis do not have abnormalities on the CSF exam. Their CSF exam is completely normal. So if you have a patient who has new onset tinnitus or hearing loss, and there's no reason for them to have that, and they have serological evidence of syphilis, then you're going to probably treat them for presumptive otosyphilis with 10 to 14 days of IV penicillin. So you do not need a lumbar puncture for otosyphilis or for ocular syphilis alone. If you have neurological findings, remember our patient had photophobia and neck stiffness, those are indications for a lumbar puncture, so you can make sure you diagnose the cause of her meningitis. And so, does the patient need a CSF examination? So our patient had ocular findings, but she also had neurological findings concerning for meningitis. And the answer in this case would be yes, even though it may not change the treatment in this patient, which was going to be 10 to 14 days of IV penicillin. You want to make sure that it's syphilis that's causing her meningitis and it's not some other pathogen like a herpes virus or a bacterial pathogen. So you're doing the lumbar puncture in this patient to make sure that you don't miss another diagnosis other than syphilis. And so who should get a lumbar puncture? Anybody that has neurological signs or symptoms, anybody that is diagnosed with the late complications of syphilis, cardiovascular or gummatous syphilis. You're not going to see a lot of those patients. But if you suspect that you have a patient with late cardiovascular or late gummatous syphilis, the first step is to do a lumbar puncture. If the lumbar puncture is abnormal, which it will be in about 30% of patients, you're going to treat with 10 to 14 days of IV penicillin. But if the lumbar puncture is normal, you can treat their cardiovascular or gummatous syphilis with 3 doses of benzathine penicillin G IM. So it makes a difference in terms of treatment. And then you're going to consider a lumbar puncture if the patient has an increase, a 4-fold increase in titers, just like what Dr. Senya described a little bit ago, or if their titers don't come down and they have high titers, 1 to 64 or greater, you can consider a lumbar puncture. These are the 4 main indications for a lumbar puncture. The most important one is neurological signs or symptoms. Always, always, always do a lumbar puncture if they have neurological signs or symptoms. Certainly consider it with cardiovascular or gummatous, and then you can consider it when their titers don't do what you want them to do. Now, I'm going to highlight one thing that we didn't put on our slides earlier with titers, and this is an important point. If you're starting with low titers, let's say a patient comes in and they have a titer of 1 to 4, and you say, okay, I'm going to treat them for unknown duration syphilis. When you're starting with low titers, don't expect those titers to come down 4-fold. They could come down 4-fold, but when you're starting with very low titers, they may not go down 4-fold. So keep that in mind. It's okay. And as long as the titers don't go up 4-fold, you're going to be fine. So, and as long as the patient is doing well and has no signs or symptoms consistent with syphilis. So if the patient is doing well, if they deny reinfection and the titer hasn't come down and you started with a relatively low titer, you don't have to do anything anymore. You're fine. And so these are the reasons to do a lumbar puncture. I've already covered what's on the slide. Keep in mind, a normal CSF exam rules out neurosyphilis, but it does not rule out ocular or otic syphilis. And remember that a patient with ocular only or otic only signs and symptoms does not need a lumbar puncture. They just need to be examined. And if you feel clinically that they have ocular or otic syphilis, you need to treat them with 10 to 14 days of IV penicillin, the same treatment that we use to treat neurosyphilis. Now, how do you make a diagnosis of neurosyphilis? People always get confused about it. And this is the approach that we take when we're making a diagnosis of neurosyphilis. So you do the lumbar puncture, and you get the first test that I look at is the CSF VDRL. Is the CSF VDRL reactive? If the CSF VDRL is reactive, then you make a definitive diagnosis of neurosyphilis. It is the most specific test, but keep in mind that 50% of patients with neurosyphilis will have a normal CSF VDRL. So it's not sensitive, but it's specific. If you find it, they've got neurosyphilis. But let's say the patient has a negative CSF VDRL or a non-reactive CSF VDRL. The next thing that I look at is the white cells in the CSF. Do they have increased white cells in the CSF? For patients that are immunocompetent, greater than 5 white cells per milliliter. And if they are HIV infected but not on ART, it's usually greater than 20 white cells per milliliter of CSF. And so if they have CSF pleocytosis, elevated white cell count, if the answer is yes, then you can make a presumptive diagnosis of neurosyphilis, unless there's another diagnosis that could explain why their white cell count is elevated. It's the diagnosis of neurosyphilis, and you can treat them with 10 to 14 days of IV penicillin. But if their CSF VDRL is negative and they don't have elevated white cell count, you're left with the protein concentration. And that never feels great because the protein concentration is the least specific parameter. And so you look at that protein concentration. If it's very high, you can certainly make a diagnosis of neurosyphilis based on a very high protein concentration, and you can treat them with 10 to 14 days of IV penicillin. But if it's only slightly elevated, it becomes more tricky. Now, the good news is if the protein concentration is normal and there's no inflammation and there's a negative CSF VDRL, you've ruled out neurosyphilis. But if the protein concentration is elevated, one possibility, just treat them for neurosyphilis. The other possibility, you can send a CSF treponema antibody test, a CSF FTA, or a CSF FTA ABS. If the CSF FTA is negative, non-reactive, then essentially you've ruled out neurosyphilis. If the CSF FTA is reactive, the problem with the CSF FTA is it's very sensitive but not specific. So you can't make the diagnosis based on an elevated or reactive CSF FTA, but because the protein is elevated, you would probably treat them for neurosyphilis. So again, starting with the VDRL, if it's reactive, you made a diagnosis of neurosyphilis. If it's not reactive, look for inflammation, white cells. If you have white cells, then you can diagnose them with neurosyphilis and treat them. But if they don't have white cells in the CSF, you look at the protein. If it's very high, just treat them for neurosyphilis. If it's not very high, you can get a CSF treponema antibody. If it's non-reactive, you've ruled out neurosyphilis, even though the protein is a little bit high. But if it is reactive, you can decide to treat them for neurosyphilis. So this algorithm should help you manage patients when you get a CSF examination. Remember, you should not get a CSF examination if it's ocular only or otic only symptoms. This is just for neurosyphilis. So our patient, remember, had a headache, photophobia. So she underwent a CSF exam, and she was found to have a white cell count that was elevated. Her protein was very high, but her CSF VDRL was non-reactive, but we know that it's not a very sensitive test. So she clearly has neurosyphilis, and she's treated for her neurosyphilis and ocular syphilis with 10 days of penicillin. The ophthalmologist said, listen, I want to give her 10 days of steroids too. I want to give her prednisone for her uveitis. The question is, should you use steroids to treat ocular syphilis? And the answer is nobody knows. We don't have any data on whether the steroids are beneficial or not. And so the CDC treatment guidelines don't recommend them. Having said that, with my patients, if they don't have a contraindication for steroids, I usually am happy to give them 10 to 14 days of steroids. Excuse me. So with my patients, if the ophthalmologist says, I really want to give steroids, if they don't have a contraindication, for example, if they're not a brittle diabetic. If they're a brittle diabetic, I say no. But if they're not a brittle diabetic and they have no other major contraindications for steroids, I'm perfectly fine doing steroids. Usually, I do 40 milligrams of prednisone, and I use them for at least 10 to 14 days. If you stop steroids too early, their symptoms may get worse, and then you sort of have to decide, what do you do? Usually, I just start steroids again, and I give 3 or 4 more days of steroids, and usually the symptoms tend to go away. So with steroids, there are no data. You can choose not to use steroids. That's perfectly fine. But if you decide to use steroids, use at least 40 milligrams for at least 10 days, and usually you're going to be just fine. Also, sometimes ophthalmologists for superficial eye lesions will use topical steroids, and those are perfectly fine to use as well. Now, you finished treating your patient with 10 days of IV penicillin. The question is, should you give additional doses of benzathine penicillin G at the end of these 10 days? The CDC guideline says some experts recommend additional doses of benzathine penicillin G. So should you be using it? I'm going to make your life easier by telling you what I do. I never, ever give additional doses of benzathine penicillin G after the 10 to 14 days of IV penicillin. The reason is there are no experimental data to suggest that additional doses are beneficial. We just don't have any experimental data on that. And then we have decades of clinical data that show us that 10 to 14 days of IV penicillin is more than adequate to treat neurosyphilis. So the answer, whenever somebody asks, should I give additional doses of benzathine penicillin G after the 10 to 14 days of IV penicillin, I usually say, don't give any additional doses. You're good to go. But if you feel better giving additional doses, and some people do feel better, and the argument is this: we treat latent syphilis with at least 24 days of penicillin concentrations that are treponemicidal. Why should we not treat late neurosyphilis with the same duration of treatment? So if you are somebody that strongly believes that you want to give additional doses of benzathine penicillin G, by all means, you can do it, but I would only give 1 additional dose. After the 10 to 14 days, if you give 1 additional dose of benzathine penicillin G, you're going to get 10 to 14 more days of treponemicidal concentration, which would get you to 24 to 28 days of penicillin, which is great. So you don't have to use additional doses. I don't use additional doses. I don't think Arlene uses additional doses. But if you choose to use additional doses, give 1 more shot on the last day of IV penicillin, and that should be plenty. Then the question is, this patient was just diagnosed with neurosyphilis. We treated her. Do we need to do another lumbar puncture in 6 months to make sure that she's gotten better? The good news is, for most patients, the answer is no. You do not need to do any more lumbar punctures, assuming that, 1, clinically, they've gotten better with treatment. 2, serologically, their RPR titers have started to come down nicely. And 3, at the time of diagnosis of neurosyphilis, if they were living with HIV and not on ART, you would have to do a 6-month lumbar puncture. So as long as they're clinically better, as long as their titers are starting to come down, and as long as they're immunocompetent, or if they're living with HIV, they're on antiretroviral therapy. If all of this is true, you do not need to do any more lumbar punctures. Now, if the patient gets worsening symptoms, etc., of course, you do a lumbar puncture. But as long as everything is going swimmingly well, you do not need to do a lumbar puncture. So remember, our patient was on ART. She was doing great. Our patient, hopefully, she got her treatment. Clinically, she did well. Her titers started to come down. She would not need any additional lumbar punctures done in the future. So, ladies and gentlemen, today we covered how do you essentially manage serological titers, how do you interpret serologies, and how do you manage and diagnose neurosyphilis, ocular syphilis, and otic syphilis. And so now I am going to hand it back over to Falana, who is going to lead our Q&A. Thank you very much.
Hi, thank you so much, Dr. Senya and Dr. Ghanem on doing such an excellent job. So we're going to go through these questions, and I'm going to try to kind of lump some of them in categories. Can you talk a little bit about, patients who might do DoxyPEP for a prolonged period of time? And in particular, like if we have patients who opt to take it like every other week for like 6 months or so, regardless of whether or not they have a known exposure. So they're kind of using it outside of what we have recommended in terms of the 72-hour window, and they're using it for a prolonged period of time. Can you talk about that?
Sure. So I'll take that one since I covered the DoxyPEP part. This is no man's land is what I call it, or no person's land is what I call it. The answer is you're going to have to use your best clinical judgment, right? So if somebody is taking long-term intermittent doxycycline, it certainly can have an impact on their clinical presentation of syphilis. It can have an impact on their serologies. Even the occasional dose of doxy can significantly impact syphilis serologies. I've had patients whom I've treated with doxycycline, and they come back to me a month after I start the treatment, and they say, "Doc, when I left the clinic, I took 1 dose, and then I lost my treatments." When I check their RPR titer, sometimes the RPR titer has come down 4-fold, even though they took 1 or 2 doses of doxycycline. So it becomes more challenging to interpret those results. And I think the lesson that you learned from Dr. Senya today with titers is that you should never interpret a serological titer without a clinical history. You always need that clinical history. And if you feel that the patient's titers have not gone up 4-fold, but the patient could have been reinfected, then by all means, treat them for syphilis. It's better in this case to overtreat than undertreat. That's my response. I don't know if Arlene has a different take on it.
I agree with that.
Great. Another kind of category was having to do with the fact that, when we talk to our patients about the fact that their RPR may take up to 24 months to show a 4-fold decrease, how do you counsel your patients in terms of when it's okay to have sex again?
Okay, I'll take that. So actually we know from data, historical data, and actually, a really good point here is that treponema powder, if you're using benzathine penicillin, clearly is highly effective. In early syphilis, let's say you treat with benzathine penicillin, is that you would probably expect the spirochetes to be killed in roughly 10 to 14 days. So I would say, we could probably still be conservative, but I would say for early syphilis, you treat benzathine penicillin, then maybe it's fine for them to have, sexual intercourse, with a treated partner. Of course, that's the key, treated partner in 2 weeks. However, with doxycycline is that it is, what we think is a secondary, treatment regimen. With doxycycline, I think the data may be less clear. Clearly we're going to be treating with doxycycline, and compliance may be an issue. So I don't know, maybe Kulu has certain thoughts on that. Now, if you're talking about late syphilis, typically we do treat for 3 weeks of benzathine penicillin. I think in that case, you're treating latent infection. Typically, you don't think of them as being really infectious. So maybe the 2-week mark is also appropriate. But as I said, with doxy, you're going to be treating with 14 days versus 28 days for early versus latent. And, you certainly want to, just to be consistent with other STI treatment, is that you probably want to advise that, they should refrain from sexual activity, or at least refrain from unprotected sexual activity until completion of treatment and treatment of their sexual partner.
Yeah, I agree with you, Arlene, completely. I think a very important point is getting the partner treated. That's really important.
Absolutely. Okay, another category was having to do with the CSF VDRL. So it's a tool to assess for neurosyphilis, but it sounds like it's not hard and fast. So if it's non-reactive, this doesn't necessarily rule out neurosyphilis. Is that correct? Because we
That
have
is
to go through that whole line.
That is absolutely correct. So remember, the CSF VDRL is helpful if it's reactive, because then you've made a diagnosis of neurosyphilis. But if it is not reactive, our patient had a non-reactive CSF VDRL, but she still had neurosyphilis. And so 50% of patients who have neurosyphilis will have a non-reactive CSF VDRL. So the CSF VDRL is helpful when it's reactive, but it doesn't rule out neurosyphilis when it's non-reactive.
Great. Thank you so much for that summary. Okay, so now we're going into the land of sort of like presentations of otic syphilis. There was on the slide, there was mention about, the prognosis for otic syphilis. What about for ocular syphilis? And what kind of manifestations of ocular syphilis have you typically heard of or seen? Does nystagmus fall into that?
Great question. With ocular syphilis, remember, any part of the eye can be involved with ocular syphilis. So you can have conjunctivitis. The most common clinical manifestations are uveitis. And the most common form of uveitis is panuveitis, both anterior and posterior. But you can see iritis, you can see anterior uveitis, posterior uveitis, you can see scleritis, you can see optic neuritis. All of these are associated with syphilis, but the most common being uveitis. So those are the clinical manifestations. Prognosis is like with neurosyphilis. Prognosis depends on duration of symptoms. If the duration of symptoms is short and you treat them very quickly, the likelihood that they're going to get better is much greater. On the other hand, if the symptoms have been present for weeks and weeks and weeks and months, sometimes you do get complete resolution, but often there's not complete resolution. And the goal of treatment in that case is to stop further progression of disease. So I always tell my patients when they've had short symptoms, I always say, you know what, I'm optimistic that we're going to be able to get rid of these symptoms, but I can't guarantee it. With patients that have had long duration of symptoms, I'll say to them, listen, the goal of treatment is going to be to stop the progression of this infection, but we may not be able to reverse all of the symptoms that you've been having. So I always lay the groundwork so that they're not disappointed. But in many instances, even with long duration, patients get better.
That's great to hear. Another common theme that came up a lot was this 10 to 14 days of treatment for neurosyphilis, because we say it over and over again. How does one decide between 10 days and 14 days? Are there any guidelines in terms of that?
There are no data to tell us whether 10 days or 14 days is better. I'll tell you what I do. I do 10 days, and I'm really happy if I can get 10 days into my patient. So I do 10 days, and I never do additional doses of benzathine penicillin G, and I'm very happy. Now, I'll just mention, when penicillin was first introduced, they were using different durations of treatment. The shortest duration of treatment that was found to be effective for neurosyphilis was 8 days. And then we have relatively limited data for 8 days. Most people used about 10 to 14 days, and that's why we say 10 to 14 days of treatment. It is possible that shorter treatment is just fine. We just don't have any data. So what I always do, I say 10 days, and then if you get 10 days in, you're good to go.
Awesome. And then someone wanted to know about, kind of our experience with steroids in treating, the symptoms. They're not in the recommendations. So what is sort of the rationale for doing it? And do you feel like it makes a difference?
So let me answer the question. I think steroids make a difference when you have inflammatory lesions related
Okay.
to syphilis. Now, many manifestations like uveitis, anytime you hear itis, itis means inflammation, uveitis, scleritis, those are inflammatory lesions. And usually steroids help significantly with inflammation. And so patients tend to respond more quickly if they have inflammatory lesions if you give them steroids. So in my experience, I think steroids help patients with inflammatory lesions get better quicker. But you have to use the steroids at an appropriate dose, which in my experience is about 40 milligrams of prednisone, and you have to use them for an appropriate duration of time, which in my experience, at least 10 days. If you stop too early, the patients can relapse. They can say, oh my God, I feel worse today. I was feeling so much better and now I feel worse. Don't panic. Restart the steroids, give them another 4 or 5 days of steroids. And usually when you stop the steroids, then the patients will be fine. So if you're going to use steroids, use them appropriately at an appropriate dose for a reasonable duration of treatment. But keep in mind, you don't have to use steroids. And the CDC doesn't recommend it.
All right. Well, we just went a little bit past 1 o'clock. We do have some questions remaining, but I think our plan was to kind of encapsulate these questions and get back to the individuals at another time. But don't forget, we have next week's session on congenital syphilis and syphilis in pregnancy. So we invite you all back to come back for that the third part of our series. And we just really want to thank you for joining us today. This was such a great session. Many thanks to our esteemed speakers and your fount of infinite wisdom. But please do register for the last session. And thank you so much for coming.
Thanks,